So I have nothing to disclose. The goals of this session were already given in the flyer that you probably saw. Just trying to let everybody know about how substance use is a really common and undertreated illness. It's a chronic disease, and how stigma and language can be a real barrier to care. And hopefully we can educate ourselves about ways to decrease those barriers. So first of all, I just want to put it out there that substance use is a spectrum. Anybody that uses a substance is not necessarily somebody who has addiction. People move back and forth on the spectrum from being a complete abstainer to a social user to a risky user to somebody that has a use disorder. I'm going to show you some data, but lots of people in our society abstain completely. Lots of people use substances socially. Most people do not have addiction, but of people that use, about 1 in 10 people will end up with addiction at some point. And again, they can kind of move back and forth along the spectrum. This is nicotine use. I am not going to focus on cigarette cessation, tobacco cessation in this presentation. I'm assuming you guys have gotten a lot of that from other places. If that is something that you feel like you want more of, please let Darian know and we can arrange that. I have presentations on nicotine use disorder, but we're not going to spend a lot of time on that today, other than just saying nicotine is a very commonly used substance. It's the #1 cause of preventable death in the United States. It has decreased steadily since the 1960s, although there's been an uptick with the introduction of e-cigarettes, as you all probably know. Ohio, as you can see here, is sort of in the navy section, which means about 22 to 25% of people in Ohio, adults, are using some form of cigarettes. In terms of alcohol, again, this is talking about alcohol use. This is not talking about alcohol use disorder. You'll see that there are, a lot of people that don't drink, a lot of people that are light drinkers, and then there's about 15% to 20% who are moderate to heavy drinkers. And that's probably where the folks with alcohol use disorder and risky use are going to be found. Again, alcohol is the most common substance that's used. It's more common than nicotine, more common than THC or marijuana. And it's the #3 cause of preventable death in the United States. But as you can see, a lot of people are either light drinkers or abstainers. In terms of other substances, this is a little bit of a tricky graph. The dark line, the blue line, means that somebody has used it at some point in their lifetime. The green line means they've used it in the past year, and the very light sort of gray line means that they've used it in the past month. So the gray line is where people that might have an addiction to a substance are going to be found. Again, this is just talking about use in general. It's not talking about addiction. But you can see by far that THC, marijuana, and cocaine are the most commonly used illicit substances other than alcohol and nicotine. And you can also see many adults have never used any substance. About 50% of adults have never in their lifetime used any substance. And then just briefly, I'm not going to really focus on pediatrics, but just to sort of mention that many teens have never used substances either. So as much as movies and tropes talk about, teens with parties and binging, alcohol has actually decreased dramatically, over the past decades. And this graph is old. It's from 2012. But it's still in 2020, the data is still about where it was in 2012 with alcohol. Nicotine had a really lovely decrease in our teens. And then in 2015, with the increase of Juul and e-cigarettes, it spiked upward with a peak in 2019. It's now trending downward again as teens are getting smarter about knowing that lots of vapes that they were fruit flavored actually have nicotine. but it's still not back down to where it was in 2012, which is kind of a shame that because the vaping and the e-cigarettes in teens ends up being kind of a gateway to adult nicotine dependence. And then illicit drug use, even though this graph is from 2012, it stayed about the same in 2022. The data is similar to this graph in terms of, hovering around the low 20% range. So lots of people abstain. Lots of people use socially but don't have addiction. Of the people that use substances, about 1 in 10 will end up with addiction. And this is sort of the definition of what addiction is. It's that loss of control when you're using the substance. So you can't sort of just use it on Saturdays, or you can't use a certain amount. It's also using despite negative consequences. So maybe you've lost your job, maybe your grades are suffering at school, maybe you've had an accident. So you've lost control of how you're using the substance. You're using despite having negative side effects. And then the other big thing is tolerance and dependence. So you're needing more of the substance to achieve the same effect. And if you don't have the substance, you start to feel withdrawal. Obviously, that's not true for every substance. Some substances you're more prone to withdrawal than other substances, but that's sort of the general idea of what is substance use disorder. The other big thing I wanted to mention about addiction is we now sort of use a chronic disease model when we're thinking about addiction. We think of it as a primary brain disease where it is chronic. You don't cure it, and people are predisposed to it either by genetics or by environment and life circumstance or life events. And they'll have periods of recovery and periods of relapse, like lots of other chronic illnesses like CHF or so heart failure or asthma or diabetes. There's people do well for a while and they're adherent to their medication and their treatment, and then they struggle and then they do well. And really addiction isn't, the data shows that it's really not that different than other chronic illnesses in terms of frequency of how many people have it, and in terms of what you can expect for their recovery. So again, we now sort of think of addiction, substance use disorder as a chronic brain disease. And that data is supported, that model is supported by imaging studies, which I'll do in the next slide. I have honestly found this useful in my conversations with other healthcare professionals and with patients. It takes away some of the stigma, which we'll talk about a little bit later. And it really helps families and patients be more willing to engage in treatment and medications. So the general idea here is that this limbic system part of your brain, where the dopamine neurons start and then connect with your frontal cortex, that part of your brain, because of the way that substances of misuse, substances of addiction affect your dopamine receptors and your dopamine release, the limbic system, basically that pleasure center of your brain, kind of stops talking in a normal way to your frontal cortex, which is your decision-making part of your brain, your sort of more rational part of your brain. And with time and treatment, those changes can go back, but they're never really completely cured or completely, eliminated. Some of those changes will always be there a tiny bit in your brain, but they can go back to very close to normal. So again, it's substance use in addiction is altering the way your brain is talking to it. Parts of your brain are connecting, and treatment's effective. It works, but it's not a cure. And patients will often have episodes of relapse and recovery. So this is imaging. The red areas, it's a PET scan, and the red areas are showing metabolism. And you can see that there's changes in the way the brain is metabolizing, and that there's changes in the dopamine receptors. particularly in the frontal cortex. So less red is bad. So you can see sort of in a healthy person what it looks like, and then somebody that's been on meth, the brain has changed, the chemistry of the brain has changed, and then you can see when they've gotten into recovery, the brain has sort of gone back to normal, but not completely gone back to normal. So again, you just sort of need to think about if it's helpful in treating people if you think about addiction as a brain disease where you know the drugs of misuse or the drugs of addiction have kind of hijacked your pleasure reward center and disrupted sort of those connections to the frontal cortex. And brains will heal with time, but there are pathways that will remain vulnerable to relapse, pathways in your brain that will remain vulnerable, which is why, you know, relapse prevention is a whole separate topic, but definitely where patients need to invest energy if they want to stay sober. Um, just briefly, many things lead to addiction, but it's not weakness of character. We now know that about 50% of what puts somebody at risk for addiction is genetic, and about 50% is environmental. So, you know, when you're talking to a patient and trying to assess their risk of addiction, like say it's somebody who's saying, I'm about to have some teeth pulled and they want to give me some narcotics. Should I take them or shouldn't I take them? This can be helpful, like taking a family history and sort of finding out, are there lots of folks in the family that struggle with addiction? Finding out a social history. Has this person had a lot of trauma? Finding out a mental health history. Has this person struggled with chronic mental illness? And in those cases, maybe they want to be cautious about exposing themselves to substances where they could potentially have um, addiction. So, depending on where you work, it's going to affect how likely you are to come in contact with for someone who has addiction. Um, so, just out and about in your normal life, you know, in general, with the general population, you're going to see about 1 in 10 people that at some point in their lives are struggling with addiction. Um, really common. Uh, Once you set foot inside of a healthcare setting, that prevalence goes up. So 20% of the patients in a primary care clinic are going to have some sort of addiction issue. 40% of patients inside of a hospital are going to have some sort of an addiction issue. And that number jumps to 70% when you're talking about an emergency room or urgent care. And why? So it's helpful to think about like, oh, where do I work and how likely does that mean that the patients I'm seeing every day have addiction? Because sometimes addiction is super obvious or risky substance use is super obvious, but a lot of times it's kind of hidden. And we'll get to that at the case at the end. So it's important to sort of think about the fact that there's probably some hidden patients around you that are having struggles that you're not aware of. And that matters because, you know, substance use is common, it's underdiagnosed, it's undertreated, and that leads to all sorts of problems, right? It leads to car accidents and HIV and hepatitis C and losing jobs and incarceration and death. And if you don't know why the patient is in your office, you think, oh, they're just having heartburn, but actually they're having heartburn because they relapse with their alcohol use, then you're not going to, you know, you're going to be giving them a PPI, right? You're going to be giving them a reflux medication. But you know, the Nexium is not going to help them with their alcohol use disorder. So it leads to really a missed opportunity to help somebody with their substance use struggles. Obviously, the biggest sequelae, the biggest outcome side effect of substance use is dying from overdose. The rates in the United States are increasing. It's important, as I'm sure you're all already aware, fentanyl is the #1 cause of overdose death. It's out there. They're cutting it into everything. I see my patients where, you know, the fentanyl has been cut into their THC. The fentanyl has been cut into their cocaine. So they're not looking to use fentanyl, but they're accidentally ingesting it. So we'll get into it in the fourth session, but there's something called fentanyl test strips. If you don't already know, patients can use those test strips to test their substance before they use, so they can test their cocaine. In the area where I work, that's really common, where people have had accidental exposure to fentanyl through their cocaine use. Um, and with fentanyl test strips, they can test before they use and then either choose not to use or choose to use less, use more carefully, have Narcan nearby, not use alone, have somebody with them. Um, the other thing to be really aware of is that fentanyl has been pressed into lots of pills that are very convincing. They're the right color, they're the right shape, they have the right markings. And, you may have a teenager in college who thinks they're borrowing an Adderall from a friend to study for a test, and it's not Adderall. Chances are it's fentanyl. Same with Xanax or OxyContin. So I can't tell you how many patients I've had come to me who are like, oh, no, 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 this is what I'm taking and I'm getting it from a good friend. And we check their urine and there's nothing in their urine but fentanyl. So again, making sure people have access to Narcan, making sure people don't borrow meds, and are huge in preventing overdose death. Not everybody dies from an overdose. Some people can have non-fatal overdoses. So you can see here, this is my area where I work in Cuyahoga County, and which MetroHealth Center it's near. But the point of this slide is that the same zip codes that have overdose death also have non-fatal overdose, and non-fatal overdose is a real opportunity for intervention. Um, about 20% of people who have have a non-fatal overdose in the subsequent year from that will die. So they're at really high risk compared to lots of other patients that you're taking care of. If you've had somebody who's had a non-fatal overdose, huge red flag of their risk for mortality in the coming 12 months, and getting them connected, particularly if it's fentanyl, getting them connected to treatment can slice that in half. So it's just important to remember that there's lots of things we can do to prevent overdose and to prevent death. I mentioned this earlier. Addiction's a chronic illness. People will relapse. They won't be cured. It's going to kind of come and go. Treatment does work. And we'll talk more about treatment, both medications and behavioral treatment in the third session. But it's not going to cure it. It's a chronic disease. You can manage it. And the relapse rates are really similar to other kinds of, chronic illnesses. Like people with diabetes have times when their A1C is great and times when their A1C is not so great. So it's really similar to other chronic diseases, and expecting relapse is helpful if you're a provider, because then you don't get as frustrated. If you're a healthcare worker, it's helpful to sort of be like, oh, okay, this is part of the illness. And it's helpful for the patient too, to be not so down on themselves, to be like, okay, this is a learning opportunity, right? We can try to figure out what went wrong this time and avoid it next time. And special consideration with addiction is about half of people who have severe mental illness will also have about half the people with substance use will also have severe mental illness. And making sure that those folks, that like 9.2 million in green, making sure those folks have access to mental health medicine, psychiatrists, can really improve not only their mental health, but it can help stabilize their addiction. Trauma is another big one. I'm sure you guys are all super educated in trauma-informed care. But trauma is highly associated with substance use disorder. About 2/3 of people who have addiction have had major trauma. Sometimes the trauma comes first. Sometimes the trauma comes after, because if people have severe addiction, they're often, at risk. They're in situations where they're at risk for trauma. In women, especially the PTSD will often precede the onset of their addiction. So it's super common for me to find that my female patients have had assault or abuse in the past, that led that preceded their addiction. And usually, if you treat the substance use disorder, you will definitely help improve their PTSD if they have PTSD. Not everybody with trauma has PTSD, but if they have PTSD, treating a substance use disorder will definitely improve that. Okay, so hopefully we're now going to be moving into a more interactive part of this discussion. Just throwing it out there. One of these things is true. Everything else is false. Does anybody want to tell me their guess?
True addiction mostly affects certain types of people.
So that could be true if by certain types of people you mean people that have had trauma or people that have had genetics in their family. So that's a great point.
Are
I guess when I wrote that book,
are they not together? Sorry, I thought the one was.
When I wrote that question, and thank you for pointing that out. When I wrote that question, addiction mostly affects certain types of people, I was kind of thinking of, I've definitely heard a lot of healthcare workers saying those people. And that's what I was trying to get at. Like, you know,
Yeah, I didn't realize that the last section was not all one question. Sorry, my eyes are playing tricks on me.
No, I'm not very tech savvy. There should be a little white line between every one of these statements, and they're all separate questions. So sorry about that.
So it's the last one.
Yes.
Addiction is like diabetes and hypertension.
Right.
It's chronic.
Exactly.
Chronic illness.
Right. So, right. Addiction is not a moral failing. It's not a choice people make. It doesn't only happen to people who live in certain neighborhoods. It's not a sign of weakness. It's a chronic brain disease. And thinking about it as, if you have a high risk patient, either based on their genetics or their history of environment, and they have repeated drug exposure, they're at a high risk of developing a brain disease and of addiction. So stigma really gets in the way of recovery. Patients with substance use are viewed far more negatively than patients with other illnesses. Can you guys give me examples of what you've seen in terms of healthcare workers approaching a patient with addiction with stigma?
Saying that they're drug seeking.
Right. That's a great one, How come some people who are in pain and want pain medication are considered, it's appropriate, and other people you say, oh, they're drug seeking.
Yeah, that's the biggest one.
Right. Okay.
A comment in the chat.
They have behavioral health needs as well. They assume that they, have another, like a mental health disorder.
What were you going to say?
Yep, just some comments in the chat. Assume they are poor. They often think that all behaviors are drug related.
And addiction cuts across socioeconomic status. It may affect like your ability to access care or, how much stigma you receive when you walk into the doctor's office, but it does not affect whether or not you end up with an addiction, what your income. So I keep repeating myself, but I'm just trying to get the message across. Addiction's super common. People don't get treatment. So 1 in 10 people have addiction, just like, similar rates to diabetes and heart failure and high blood pressure and high lipids, but only 1 in 10 people with addiction actually end up getting treatment, which for me, if I just sort of pause and try to imagine only 1 in 10 people with asthma getting an inhaler, it just doesn't, it's very similar, right? It's kind of, it should disturb you to think about it that way. Because it's a huge disparity in how we're approaching a really common treatable illness that is has a high level of mortality depending on the substances they're using. So stigma gets in the way of treatment. For patients, the stigma makes them hesitant to ask for help because they are afraid they're going to be shamed or judged. And for healthcare workers, the stereotypes kind of get in the way of them doing what they do really well, which is offering help and offering compassion. This is kind of a technical slide for people that are, interested in sort of public health approaches to diseases, but people that are experts on stigma think about it as like it can be institutional, right? It can come from the healthcare providers or it can come from the patients. In terms of institutions, it affects things like a choice of whether or not, city council is going to invest in syringe exchange vans, or your pharmacy is going to choose to offer Narcan, because I'm sure you've all heard people say, oh, well, syringe exchange is just going to encourage use. Or, if we give people Narcan, they're just going to have Narcan parties. I've heard that, and it's not true. There's actually good data that it saves lives and it helps people engage in healthcare and recovery. There's social stigma among providers, like you guys talked about, where people make judgments. I definitely have heard when I'm trying to convince my fellow family doctors to do buprenorphine, I get a lot of, those people, or not a lot of it, but a lot of, I'm afraid to give somebody buprenorphine because then there's going to be a line out the door. I've never heard a physician say that they're afraid to give insulin because then there's going to be a line out the door, right? So it's that's sort of the healthcare level of stigma. And then, as I mentioned, patients have tons of shame. In lots of diseases, the self-image of a patient will kind of decrease or become impaired as the disease has really progressed, right? So somebody with end-stage COPD or emphysema who has trouble walking a few steps will start to, feel bad about themselves. With addiction, the self-image, the self-worth comes way at the beginning. People feel really bad about themselves right from the start with addiction. And, we need to address all of this if you want to get people engaged in treatment, right? Like you've got this common illness that's super treatable and only 1 in 10 people are getting treatment. And you've got to kind of think about this in your career, in your workplace, if you want to change that. Language matters. How you talk about a patient matters. How you write about a patient in a chart matters. They've done these really nice, clever little studies. Well, they'll write a note and then show it to like med students or doctors. And depending on the words you choose in that note, it totally changes the level of empathy of the person reading the note. So if you in the note call the person an addict, a junkie, an abuser, talk about their dirty urine, people reading the note are going to be much less likely to want to help the patient get connected to evidence-based treatment. And again, this is like anything else, any other chronic illness, you want to use person-first language. So it's a person with fentanyl addiction. It's a person with opiate use disorder. You don't want to say heroin addict. Of course, we wouldn't say heroin addict anymore because it's really not heroin anymore. But you wouldn't want to say a fentanyl addict. So language matters in terms of the quality of care that patients end up getting, and how they're treated. This is kind of a repeat slide. You really just want to be careful what you say. It's a chronic illness. We can treat it successfully, but you have to have compassion in addition to all your usual skills as a CHW, if you want to be able to connect with patients and get them to trust you. And this slide kind of gets into motivational interviewing. We'll talk a little bit more about motivational interviewing next week in the next session. But as you guys probably already know, you've probably already been trained in motivational interviewing. It is really trying to get providers to move away from a model of wagging their finger and lecturing and move toward a model of, collaborating, and being curious and non-judgmental and reassuring patients that, change is possible and you're going to help and you're going to collaborate with them. I'm sure any of you that have changed any behavior, like whether it's trying to go to the gym more often or eat less sweets or any behavior, going to bed at a certain time, you didn't get there if you were able to successfully change your behavior. You didn't get there because somebody scolded you or somebody lectured you. Usually people get there because they start talking about change. They start acknowledging their own ambivalence and figuring out that they're motivated, they're ready, and that change is possible. And like I said, we'll talk more about that next week, but it's really important when you're talking to a patient also that you're clear on what the patient wants and what's the patient's goal. I can remember I don't think it was last year, the year before, one of my addiction medicine fellows was saying to me, like, well, they're not off all substances, so, I don't know why we're even taking care of them. And I was sort of like, well, if we only treat people where we expect perfection and allow perfection, then we're missing a lot of folks in any area of medicine, right? Like if we only take care of our patients who, are compliant with their asthma and their diabetes medicine, then there's going to be lots of people that we're not helping. So you really have to know what the patient's goals are. I may not love the patient's goals, and I try to work with them on changing their goals to something that's healthy.
It's ongoing, or if it's just for a few weeks to help you get through this hump. Yeah.
I'm sorry, I didn't catch that. Was that accidental maybe? Or was that a question or comment? So here I'd love to just spend some time talking about self-reflection. Are any of you comfortable sort of thinking about a time when you, either at work or maybe outside of work, you encountered someone with addiction and how you sort of felt about their substance use? I know for me, like if I think back 20 years, I often wish that I knew then what I know now. Maybe there were times when I had feelings or thoughts about a patient who was struggling. And I maybe was more judgmental because that was kind of the thinking back then or the training back then or whatever, my own failings.
Yeah, with where I was when I was in my early 20s, I definitely carried a lot more judgment and less compassion than I do. I recently did work with a client who is a in and out of recovery meth user. And it just hurts my heart. It just hurts my heart for him and his family, knowing that he wants to be well. And the lack of timely access to resources is a huge barrier. He wanted to go inpatient, but they had a 2-week wait.
Oh,
and so he didn't. We're back to square one.
So I have page with how to connect people to resources, but you're right, especially for those of you that are working in rural areas, it can be really hard to connect people to treatment. Is my connection still good? Okay. The other comment that you said that struck me, all of it was beautiful, but part of it that struck me particularly was the idea of nobody wakes up in the morning and decides, oh, I want to have addiction. It's not a choice. It's not something people are usually happy with. They often want change, but as you know, again, if you've tried to go to the gym or start getting to bed early or whatever, use your cell phone less often, change is really hard. And maintaining change is really hard. Other thoughts that people have had when they've encountered somebody with addiction?
For me, I'm big on meeting people where they're at. So it's never like a judgmental thing. And it's really just, hey, if they're not ready to get help at this point, let me just help you with what you need now. And then that the door is open. So sort of just like being that support, being there, but never like judging or telling them what they need to do.
I love that. You're way ahead of the curve from where I was before I got my training. Yeah, if you are non-judgmental and you are collaborative and that person leaves your office, your workplace feeling respected, they're going to come back to you. And over time, they are going to work with you when they're ready. I have people who come back to me years later. So, you know, as long as they're alive, it's never too late to change.
Yep, that harm reduction approach
Yeah. And
makes a world of difference.
Yep. And that's going to be our 4th week together, is we're going to take a deep dive into harm reduction. And I'm hoping, you know, you guys are going to share with me what you're all doing in your different cities so that we can learn from each other. Any other self-reflection about a patient or a friend or you know, something that happened when you were encountering someone with addiction? I don't know. Is there anything in the chat, Darian? Otherwise, I can move on to the case.
Yeah, just kind of the same points of having the adequate resources that they have now, to point patients in that direction with that information.
So-
I like something
Sorry.
real quick. I just think that maybe this is some information that hospitals should share in just general when you go for your annual physical, because a lot of people are not going to share that they use a substance. Like a lot of people right now are using marijuana. And a lot of it may be used recreational, but this also leads to the use of other drugs. And I put in the chat earlier and just said, this hit home for me because, within the last couple of days, we lost a family friend.
I'm so sorry.
Who actually was using, I didn't even know they were using that kind of drug. They were using, I guess they tried cocaine or something. And I was like, really? Like on the inside of me, like you said, this prejudging, I was like, whoa, wait a minute. Like, I was like, wow, like, I guess it's common that people might use marijuana for recreational, but I just didn't know anybody that I knew that may have used cocaine. And today was the day where the family had to pull that person off of life support. So for me, it hit home like, wow, this is really happening in people's real life.
Right.
So I'm really grateful for this call today. Like, wow. So thank you.
So sorry for your loss. And I think the key thing that you said is you weren't aware, but we are all surrounded by people who are struggling. Right now in this moment, as soon as this call is over and we step into the next part of our workday, we're driving home, we're all surrounded. Like, since I started doing addiction work, like every time I go to the doctor, for myself, and I sit down and either the medical assistant or the nurse is checking me in and checking my vitals, and they're like, oh, what do you do? And I say what I do, the stories come every time, their friend, their family member, their coworker. It's just something we don't talk about nearly enough and that people aren't comfortable talking about. So I'm very sorry for your loss. It's just awful. And information sharing between institutions was one of the first things you mentioned when you were talking. And unfortunately for like me, where I work in an addiction clinic, there's this whole thing called 42 CFR, which is like this layer beyond HIPAA, where it makes it really hard for me to share my information. And those of you, like I saw somebody in the chat was from Oriana, like, you know what I'm talking about. But other hospitals can share a little more easily between hospitals under HIPAA laws, like if you're not an addiction provider. But the federal laws need to change to make it easier for us to communicate amongst ourselves so we can help patients.
Thank you.
So this case I'm going to discuss, I would really love next time if somebody can, either shoot Darian an email with a case or shoot me an email with a case. I'd much rather have somebody present a case and then we discuss it. Next week, we're going to be talking about screening. So if you have a case related to screening, that would be great. I guess this case is honestly a little bit related to screening. This is one of my patients who I took care of a year or two ago. She's a 33-year-old woman, single mom, 2 kids. One of her kids had special needs. And then she had a teenager, which any of you that have a teenager know is stressful. And she had seen her PCP multiple times since COVID started. And she went for anxiety and for palpitations and for heartburn. And finally ended up in the emergency room with chest pain and admitted, because she was scared, that she had been drinking again. Like she had quit drinking for years and COVID just kind of knocked her off her sobriety. She had the stress of homeschooling and in addition to single parenting, and she had lost her job because she had worked like a front desk at a health clinic, and the clinic was now telemed, so she didn't have work. And she was super isolated. So each night she would go to her car and once the kids were in bed and just kind of sit outside of her apartment in her car and drink and talk to her best friend on the phone. So that is a case where if we had been doing screening, which we'll talk about, I believe next week, she would have been caught much sooner and we could have offered her help sooner. But anyway, she did eventually talk about her struggles with alcohol and get plugged in to help. But I'm wondering if you had been the first person to meet her, like say in the emergency room, and she sort of said, "Hey, I'm drinking," like, how would you approach it? Like, what would you say? What would you not say?
I will ask her how often is she drinking? Why is she drinking? What's contributing to her drinking? That will open up more conversation as to what's going on to reach that deeper problem.
Love it. I love that sort of curiosity. And a small tip I would say is often when we say why, people get defensive. But if you instead are sort of curious and say, what role is alcohol playing for you? Like what are the good things, the bad things? That can be, or a normalizing statement like, yeah, lots of people drink, not everybody, as we've established, but lots of people drink. And tell me about what role that's playing for you. So I love that. I love your curiosity and trying to dig a little deeper into what she's doing and how it's a part of her life. Other folks?
Just a comment in the chat. I would lead into sympathizing and validating the stressors that she is experiencing while offering alternatives / harm reduction approach.
Yeah. So empathy is great. We all love to feel understood. Other thoughts? What would you avoid saying?
You shouldn't do that.
Yes, no shoulds.
You know better. You have kids. You shouldn't. Again, you shouldn't.
Amen. I was hoping somebody would say that because I wish I had a nickel for every time, particularly a mom has been shamed about, their you're not a good parent if you're struggling with addiction. And don't you love your children? And how could you do this? And all sorts of those kind of things.
Like chances are they already are carrying guilt and shame, knowing that it's detrimental to themselves and their family. And then adding that, like, they don't need to hear it from other people. They need to hear that, yeah, that's hard. I get it. Let's try to make it less hard.
And change is possible.
Yeah.
Right. Right, right. But like we talked about, like that self-shame with addiction, both for men and for women, that comes right from the start. And particularly, parents, that's a huge one. And in our society, because we often, put some of the extra burden of child rearing on women. And during COVID, in particular, women with young children, there was a huge spike in drinking.
And some comments in the chat, just stop drinking, it's not that hard. And not to say, oh, you were doing so well.
Yeah, my husband, he's also a family doc, and he said he was just walking through the emergency room the other day and somebody was wagging their finger, like, yelling at the patient to stop the nicotine. And, just doesn't work. So yeah, and definitely, like you already know, avoiding language like calling somebody a drunk or an alcoholic, or, that they're weak, or, anything that's shaming. It is nice if you can sort of dig in a little bit to sort of what are the pros and cons of alcohol, and talk about ambivalence, which we'll get into next week. But anybody that uses substances, there's good things about it, or they wouldn't be using it. And there's bad things about it. And sort of digging into that ambivalence helps people feel seen and safe, and helps them sort of move along the spectrum in terms of their readiness to change. Sometimes talking about what are their past successes, like what's worked for you before, can be super helpful. And trying to, and for sure you should be, touching on safety. You're not going to call children's services, but it's good to talk about, the patient's safety. Like she's drinking in her car at night, but does she have the keys? Is she driving somewhere? And how sure are we that the kids, when she's drinking, are okay? But please send me cases. Does anybody, how about if folks just take turns doing these 10 questions? Somebody just talk through question number 1. These are all pretty straightforward. Whoa, maybe they're not. Maybe they're tricky again. Maybe I worded them badly.
Number 1, anyone who uses drugs has an addiction is false.
Right. As I said, like multiple times, lots of social use, or people that are using for medical reasons. Number 2.
Substance use disorder is defined as chronic use despite negative consequences. That's true.
Yeah, that's how we think about it now. 3.
Addiction is 50% due to genetics. We now know that this is true, that it's not always a choice. It's not a choice. And that epigenetics play a huge factor.
4.
Substance use disorder is a moral failing, false.
Right. Yeah. People aren't weak. They're not bad. There's lots of different things that go into people starting down that road of addiction. 5.
SUD is very unusual. That is false.
Correct. Yeah. As I've been saying over and over, super common. 1 in 10 people have addiction. And yeah. 6.
SUD can be cured. No.
Right. As I've said over and over, it's chronic illness. You're going to manage it. It's going to relapse, recovery. And the goal is that their episodes of recovery get longer and their relapses are less frequent. 7.
SUD can be cured. Oh no, wrong one. Most people with SUD do not get treatment. That's false. Right, 7.
So actually 7 is true. So
Sure.
about 90% of people with addiction do not get help. Only about 1 in 10 people who have addiction get help. And that's where like anything we can do, like the way you were talking about how lovely you are with your patients who have addiction and the language you use and the approach you use, you are helping knock down that barrier and making it much more likely that your patients with addiction are getting help. But unfortunately, we've got effective treatment. It's just 90% of people aren't accessing it for lots of different reasons.
Mhm.
Number 8. Anybody?
There is no treatment for SUD thoughts.
Right. There's great treatment, behavioral treatment and medications. Number 9.
Shame and stigma are barriers to treatment. True.
Perfect. Okay. And then I think we've already talked about stigmatizing language. I think people have talked about recovery language. I'm going to skip to the next slide just in the interest of time. Oh, here's some examples of stigmatizing language: junkie, addict, drug abuser, dirty urine. And then recovery language would be talking about a person with a substance use disorder. So I want to make sure everybody sees this slide. There's a 1-pager that Darian is going to share with everybody. But if you're not already familiar with your county's Adams board, get familiar with your county's Adams board. They can be a great way to get get your patients connected to resources. And if people have other ideas, there's also a SAMHSA national helpline. But please put it in the chat if you have other suggestions of ways that you connect your patients to resources. Gonna try to share the 1-pager. Well, let me finish this and then I'll switch over to the 1-pager. But yeah, if you connect with your county Adams board, and you can find your county Adams board if you don't already know them by going to this OACBH website, and then call them, or use their, the county Adams board website to find out what local programs do you have. And like I said, some areas are going to have more access, and other areas it is harder, particularly some of our rural areas. It's harder to get patients connected to treatment. These are some of my favorite resources. I would love to see or hear about resources that you guys have so that I can add to it. I think peer support is huge in recovery. We have some medications for some addictions, but we don't have medications for all addiction. So getting people connected to peer support, whether it's through a peer support service that's paid for by your insurance, like Thrive, or whether it's through free peer support, like AA, NA, Smart Recovery, Free Thinkers, like there's tons of them. And then a lot of my patients who are in early recovery, they may need help with either legal aid, food, housing, like a lot of the basics, getting their insurance. And you guys are probably much smarter about all these resources than I am. So again, if you have hot tips on resources that are good, no matter where you are in the state of Ohio, that was sort of what I was trying to do with this slide. Please share them. And then overdose prevention, we're going to get to this a lot in the 4th session. But there's some overdose prevention resources that I'm going to have on that 1-pager. So I'm going to just real quickly show you my crude version of the 1-pager. Can you guys see this? So this is basically all the information that we just talked about on a page that's going to live on the website. And like I said, we haven't finalized the version of it, partly because I'm hoping to get some information from all of you guys to make it even better.